Check, check, check. Can you all hear me okay?
Yeah.
Yeah, we can hear you.
Thank you. You never know with this technology, but I think we're doing okay. Okay, so we're going to go ahead and get started with this session. This session will feature Dr. Ashley Paul. She is a neurologist in Baltimore, Maryland, and is affiliated with Johns Hopkins Hospital. She received her medical degree from Albany Medical College. Please welcome Dr. Ashley Paul.
Thank you. Thank you for the introduction, and nice to spend the afternoon with everyone here. I wish we could be together in person, but I'm glad we have Zoom. I'm going to share my screen here. All right, so hopefully everyone can see my slides.
Yes, looks great.
All right. So to get started, I hear this phrase a lot. Doc, I thought I was just getting old. I hear this all the time from my patients. And if I had $1 for every time a patient told me this line, I could probably pay off all my student loans. I'm also often advised to not get old, and I'll keep working on that. But in the meanwhile, I want you to think about how many times you might have had the same thought when you went to your doctor, and maybe you noticed changes in how you walk, in your thinking, in your memory, and yet you might have chalked it up to just normal aging. So today we're going to talk about how to distinguish Parkinsonian symptoms from other physical and mental limitations. Because how do we know what symptoms are normal aging, what's related to Parkinson's disease, and what is a different disease altogether? So this is a pretty big topic. I'm going to try and tackle what I can in a half hour today. And as you already heard, I'm Dr. Ashley Paul, and I'm part of the Movement Disorder Center at Johns Hopkins. So hopefully by the end of this talk, you'll have some idea of how neurologists try to distinguish Parkinsonian symptoms from normal aging and other disorders. So to first understand what Parkinson's disease is, we must first define what is Parkinsonism. So Parkinsonism is a set of symptoms. It really means slowness of movement, plus at least one of the following. So you can have slowness of movement plus tremor, rigidity, or loss of balance, what we refer to as postural instability. And oftentimes, and we teach medical students this mnemonic trap to help remember the cardinal symptoms of Parkinsonism. So tremor is one of the most common reasons for referral to a movement disorder specialist or a neurologist, but not all tremors are related to Parkinson's disease. And so every time we see a person with a tremor, we work to characterize what the tremor looks like. Knowing what the tremor looks like helps us to think about what's causing the tremor. So in Parkinson's disease, we often see a rest tremor. So this is a tremor that happens when you're not doing anything with your hands, just when you're sitting around. And it's often described as a pill rolling tremor because it looks like someone is rolling a pill between their thumb and their fingers. It's usually asymmetric, and in other words, it tends to affect one side of the body more than the other. Sometimes it just starts off with a slight twitching in the thumb, so it can be very subtle in the beginning. And then sometimes it can change over time, get larger, spread to the other side of the body. So this is different from a postural tremor. A postural tremor is a type of tremor that happens when a person holds their arms out outstretched and you see shaking of the arms. It can happen in Parkinson's disease. In fact, 50% of patients with Parkinson's disease will start off with a postural tremor before they notice a rest tremor. And an action tremor is a tremor that occurs when you're trying to do something with your hands. So you're trying to pick up your fork to eat, or you're trying to put your key in the door. You may notice a tremor, as that's called an action tremor. So there are many reasons for people to have postural tremors and action tremors. Sometimes it's related to medications. Sometimes it's related to caffeine or nicotine or alcohol withdrawal. Thyroid disease can cause all kinds of tremors. And then there's essential tremor, which is a type of tremor that runs in families and is predominantly an action tremor. Patients with essential tremors have a fourfold increased risk of developing Parkinson's disease. So even if someone only has an action tremor or postural tremor, we look for the signs and symptoms of Parkinson's as well, because there's this increased risk. Action tremor sometimes can also be seen with diseases that affect the cerebellum. The cerebellum is the back of the brain that helps control balance and coordination. But what we're mainly looking for in Parkinson's disease is the rest tremor. Because if a person with Parkinson's disease is going to have a tremor, the rest tremor is really specific towards Parkinson's and it's part of the diagnostic criteria. Now, a person with Parkinson's disease can have all three types of tremors, but 20% of people with Parkinson's disease actually do not have tremor at all. So you don't have to have tremor to have Parkinson's. And I alluded to this already, but medications are always important to consider, both for symptoms of Parkinsonism and tremor in general. So when we see tremor that occurs equally on both sides of the body and is predominantly postural action tremor, we really do think a lot about medication-induced tremors. And for example, lithium is a well-known cause of tremor, so is valproic acid, and there's many others as well. Now, the next cardinal feature that we see in Parkinsonism is rigidity or stiffness of the muscle. Sometimes patients will describe this to me as weakness or heaviness in the limbs. It's not a true muscle weakness, but the arm may not be moving the way you want it to. And sometimes in the very beginning, it could feel like a frozen shoulder. So people might complain of shoulder pain, and oftentimes they're referred to an orthopedic doctor. Some people even get surgeries long before they develop all the other symptoms that come with Parkinson's disease and then get recognized and diagnosed with Parkinson's disease. As I was saying before, the most common symptom, well, the main symptom in Parkinsonism is bradykinesia. Bradykinesia means slowness of movement. So brady is slow, kinesia is movement, so slow movement. And oftentimes my patients will tell me that it takes longer to complete daily tasks like dressing or whatnot. And maybe they've noticed that they can't keep up with their partner when they go for walks. And so to define Parkinsonism, you have to have bradykinesia. And of course, you can also have changes in the way you walk. So early signs could be just reduced arm swing when you're walking or dragging on one leg. And then as the disease progresses, the stride length gets shorter. So it looks like shuffling steps. You don't pick up your feet as easily. Sometimes people miss the stairs or miss a curb. And this leads to falls, loss of balance. There's also stooping of the posture, so that forward lean. Sometimes people also lean to one side. When people lean to one side, we call that Pisa syndrome, kind of like the Leaning Tower of Pisa. And later on in the disease, so we're talking about greater than 5 years in or more, we see more of the falls, and sometimes people develop freezing of gait. Not everyone does, but freezing of gait is when someone is trying to take a step forward and they get stuck in place and they're sort of marching in place, trying to get that momentum to go forward. And while changes in speech is not part of the cardinal features of Parkinsonism, in other words, you don't have to have these changes to call it Parkinson's disease, but it's very common that a patient with Parkinson's disease will have changes in their voice, where their voice may trail off at the end of a sentence. Now, a lot of times I see patients and one will say that it's their partner's fault that they're hard of hearing. And the partner will say that, no, you become soft-spoken over time. So I let them debate it. Now, other symptoms that can happen in Parkinson's disease is a reduced sense of smell. So I often ask this of my patients, whether they have any changes of smell or loss of smell. And most of my patients are now trying to reassure me that they do not have COVID, which also can reduce your sense of smell. But really, I'm asking about smell because smell, changes in smell, constipation, and changes in sleep can be present long before the motor features of Parkinson's disease. So sometimes these symptoms come 20, 30 years even before we see a tremor or stiffness or slowness of movement. REM sleep behavioral disorder in particular has a higher risk of showing up as Parkinson's disease later in life. So REM sleep behavioral disorder is a disease where in the middle of the night, when you're in the deepest stage of sleep, you are acting out your dreams at night. So you might be kicking, punching. Usually you don't know that it's happening because you're in a deep state of sleep, but the bed partner is the one who usually wakes up and knows that this is occurring. Other symptoms that you can see in Parkinson's are dry eyes. So we talked about slowness of movement. That same slowness happens in facial movements. And so there's this reduced facial expression and there's reduced blinking of the eyes, which can cause dry eyes. Fatigue is very common. Sometimes people have changes in blood pressure and that can cause lightheadedness. Besides REM sleep behavioral disorder, there can be other problems with sleep as well, just general sleep disruption. There can be urinary symptoms and there can be mild cognitive changes in the beginning. Sometimes it progresses on to dementia later on. Again, not everybody develops dementia, but it's a possibility later in the disease. Okay, so I just want to take a moment and pause. And if you're starting to think about questions, I want to give you a minute to write it down. I know we're going to go over questions at the very end, but I just want to take a minute here in case you're thinking about what you've just heard so far. All right, so now that we talked about what defines Parkinson's disease, let's also talk about how Parkinsonism does not always mean Parkinson's disease. So we talked about how Parkinsonism is a set of symptoms, the slowness of movement, plus or minus tremor, plus or minus rigidity, plus or minus postural instability. So you have to have slowness and you have to have at least one of these other symptoms. But there are other diseases that can cause Parkinsonism. And so how do we know when someone has regular idiopathic Parkinson's disease versus something else that looks like Parkinson's disease, but it's not? And so these are what I would refer to as red flags. If somebody is coming in for an evaluation for Parkinson's disease, but they have a rapid progression of symptoms, generally Parkinson's disease is slowly progressive. If symptoms are affecting both sides of the body equally from the start, that would be unusual for Parkinson's disease because that usually affects one side of the body and can spread to the other side. Even when it spreads, it's usually still worse on one side. Now, lack of response to levodopa, so carbidopa-levodopa is the mainstay of treatment for Parkinson's disease. And usually someone with Parkinson's disease has a pretty robust response to levodopa. The one exception is that sometimes tremor doesn't respond as well to levodopa as the other symptoms do. But in general, we usually see a good response to levodopa. And so somebody who does not have a good response to levodopa, it may make us think of is something else going on. And then atypical Parkinsonism. So that's a whole set of other disorders that look like Parkinson's disease, has a lot of similarities. Again, it has those symptoms of Parkinsonism, but it has usually a faster rate of progression. And there's other signs that are more specific to some of the atypical Parkinsonisms. For example, if somebody has early falls, they're falling quite often within 3 years of symptom onset, then that would make me wonder or think about progressive supranuclear palsy, which is another disorder that looks similar to Parkinson's disease, but is not quite the same. So other causes of Parkinsonism that we think about, one is vascular Parkinsonism. Major depressive disorder can look like Parkinson's disease, drug-induced Parkinsonism, normal pressure hydrocephalus, and like I said before, atypical Parkinsonism. And so we'll try to go through some of these. So vascular Parkinsonism is a disease that causes symptoms that look like Parkinson's, but it is related to vascular changes in the brain. And so on the left side here, we have a normal, healthy brain. And then on the right side, you see these white fluffy areas. These white fluffy areas are vascular changes that are occurring in the brain that causes symptoms that look like Parkinsonism. How does this happen? Well, longstanding high blood pressure, high cholesterol, diabetes, smoking is a big one. All of those things can cause changes in the brain over time, very slowly. So they're almost like micro strokes, if you will. Basically, they're not like large strokes or strokes that bring you to the hospital because you have these sudden onset of symptoms. But slowly over time, there's micro damage to the brain that build up and can cause symptoms similar to Parkinson's. And when someone presents with vascular Parkinsonism, a clue to that is that mostly the symptoms occur in the legs. So that's why it's sometimes called lower body Parkinsonism. Now, depression can really look like Parkinson's disease. And the reason why is oftentimes somebody who's going through depression will have facial expression that resembles the loss of facial expression, I should say, in Parkinson's disease. So we refer to that as hypomemia when there's a flattening of the face in Parkinson's disease. That same look can appear in depressed patients. Both patients with Parkinson's disease and depression can have soft or slow speech, can have a slower gait, and can have slowness of thought. We refer to slowness of thought as bradophrenia. That's the fancy medical term for that. But both diseases can have that. And so sometimes it can be hard to distinguish someone with pure depression and someone with Parkinson's disease. Now, 50% of patients with Parkinson's disease can develop depression at any stage in the disease. And this is for two reasons. One, of course, it's difficult to have a disease like Parkinson's disease. And so, your reaction to having this kind of diagnosis can make anyone depressed, of course. And then it's also part of the disease itself. If you think about it, the brain chemistry is changing, right? You're losing dopamine receptors in the brain, and dopamine is a happy chemical. And so that loss of dopamine can cause depression. So it can just be inherent to the disease itself. And what else makes this tricky too? So somebody who has severe depression may be put on antipsychotics to help with the depression. And antipsychotics can cause drug-induced Parkinsonism. It does this by blocking the dopamine receptors in the brain. So it can look like Parkinson's disease because of that blockage of the dopamine receptors. And in those cases, I often get what's called a DAT scan. So this picture here is a DAT scan. A DAT scan looks at the dopamine uptake in the brain. So on the left side here, this is a normal scan where you see sort of these comma shapes here. And a DAT scan is abnormal when they look like a period on both sides. So a DAT scan will be normal in a person who has drug-induced Parkinsonism, if it's only drug-induced Parkinsonism. A DAT scan will be abnormal if there's an underlying neurodegenerative condition that's causing Parkinsonism. So sometimes a person may not realize they have Parkinson's disease, and then they're put on one of these antipsychotics, or they take antiemetics, so medications, certain medications for nausea and vomiting can also block dopamine receptors. And this may unmask the underlying Parkinson's disease. So it can be very hard to tell whether something is related to some drug that's blocking dopamine receptors in the brain, and that's the only thing causing Parkinsonism, or if there's an underlying Parkinson's disease that's being masked by medication. Usually we'll try to remove the medication if we can, if the person can be off of the medication that might be causing the problem. But it can take 6 to 12 months for the Parkinsonism to go away. And if it doesn't go away, then that's a reason to look for a DAT scan and see if there's an underlying neurodegenerative disease going on. Now, a DAT scan cannot distinguish between Parkinson's disease and the atypical Parkinsonian disorders. So how do we know when somebody has atypical Parkinsonism? We talked a little bit about it already, but if it's more rapidly progressive, and if there are some of these signs, so early on, that's the key thing here. All of these symptoms can happen in Parkinson's disease, but they tend to happen later on. When you see early signs of drops in blood pressure that's causing someone to pass out or nearly pass out, or if they're having falls right away as soon as the other symptoms have started, or difficulty swallowing or dementia, problems moving the eyes, looking up and down, particularly looking down. Alien limb, we'll get to what that means. And incoordination or clumsiness, sometimes we see that particularly with diseases that, again, affects the cerebellum, which is the part of the brain that controls coordination. So if a person came to my office, let's say they're in their 50s, and they may have some slowness of movement, they may have some signs of Parkinsonism when I do an exam, but they're also having severe drops in blood pressure, more than 20, 30 points, and that's causing them to feel lightheaded, dizzy, or even pass out. then I would be thinking about multiple systems atrophy, which is one of the atypical Parkinsonisms. Another example here, we talked about a little bit before, but if somebody developed slowness of movement and changes in how they walk, and then within 3 years of that, they start falling backwards, and they have this sort of facial expression. This is actually a very common facial expression we see with this disease, that where a person looks sort of surprised or scared. And if they have difficulty moving their eyes, particularly looking downwards, sometimes in the beginning, that downward difficulty is just slowness of the eye movements. So looking down, it takes longer for them to look down than to look left and right. As the disease progresses, it can take, it could be even harder to just look down at all. So this disease is progressive supranuclear palsy. And then I have a video here that I've borrowed from the American Academy of Neurology Journal. This is, let's see if it plays. So this is an example of alien limb syndrome. So this woman is trying to use the napkin with her right hand, and her left hand is interfering. Her left hand keeps trying to grab the napkin out of her right hand. She feels like she has no control over her left hand, in fact, and that it has a mind of its own. So she keeps telling the left hand, stop doing that, stop doing that. Yeah, so she's saying, stay away. But the left hand doesn't cooperate with what she wants it to do. So this is called alien limb phenomenon. There's a few things that can cause it. And I think in this particular case, it was actually caused by a stroke, but we also see it with cortical basal syndrome. So in cortical basal syndrome, you see signs of Parkinsonism, that slowness of movement, stiffness, but you can also see some unusual signs like this one, alien limb syndrome. Sometimes you see what's called myoclonus, which is jerky movements instead of tremor. And the reflexes are usually increased. So when we do an exam and we see some of these signs, we think about cortical basal syndrome, which is, again, similar to Parkinson's disease, but is a different entity. Now, I'm sure this is a question that comes up quite a bit, at least it does in my clinic. When we have changes in memory, how do we know if this is normal aging? Usually I ask my patients, is the changes in your memory out of proportion to people your own age? The friends you hang out with or socialize with. And if it's not out of proportion, then it's most likely normal aging. All of us have changes or a little bit loss of memory as we get older. What's protective is the more education we have. So the more years you do after college in education, that helps put off dementia. But all of us, if we get to a certain age by a certain point, we all have risk of memory changes. Now, this can start off as what we call mild cognitive impairment. So mild cognitive impairment is when there are changes in thinking or memory, but it does not stop the person from being independent or living independently and functioning well. We call it dementia if somebody has cognitive issues that prevents them from being able to fully take care of themselves. So Parkinson's disease, you can have dementia with Parkinson's disease. Not everyone develops dementia. I always tell this to my patients because I don't want you to sit there and anticipate, am I going to develop dementia or not? There's no way to know for sure who will have it and who won't. But when it does happen, these are the particular problems that we see. So visual spatial problems, difficulty judging distances. Sometimes it can affect the way someone drives because they can't judge how well the car in front of them, how far away is that car, getting lost easily or feeling like your eyes are playing tricks on you. Memory impairment, a lot of times, a lot of people have word finding difficulties. And so that could be subtle signs of memory changes, or it could be part of normal aging too. And the big thing here is what we call executive dysfunction. So this is difficulty with making decisions, problem solving, multitasking, that kind of thing. And overall, someone with Parkinson's disease dementia will feel like their processing speed is just slower. They can't think as fast as they used to. Now, how do you know it's not Alzheimer's disease? So Alzheimer's disease is the most common cause of dementia, actually, but it has a different pattern. So someone with Alzheimer's disease have more of what we call amnestic memory loss. So this is difficulty remembering, let's say, I'm sure many of you have gone through some of these cognitive memory tests. I give you 5 words to remember, and then later on, I want you to recall those 5 words. Now, someone with Parkinson's disease may have trouble recalling those 5 words, but if I give you some clues, it will come back. Somebody with Alzheimer's dementia, those words don't come back. So it was not really registered in the brain the first time. And so that's how we sometimes suspect Alzheimer's dementia over Parkinson's disease dementia. It's not impossible to have both Parkinson's disease and Alzheimer's. A lot of us, again, as we get older, we are all at risk of developing dementia, and the most common is Alzheimer's. But the character of the changes in cognition and memory and thinking is different in Alzheimer's dementia than pure Parkinson's disease dementia. Although it should be noted that somebody who has dementia with Lewy body, when we do autopsy after someone has passed away and we look at what's going on in the brain, oftentimes in 90% of cases, in fact, we see a little bit of both dementia with Lewy body and Alzheimer's disease together in the same brain. So we're seeing that more and more, that it's common, or not uncommon, I should say, to have more than one pathology going on in the brain. But how it manifests in a life can be very different from person to person. So in other words, even though you may have that, all these diseases are caused by protein building up in the brain and an abnormal accumulation of protein that damages the brain. And so even though someone might have those proteins that we see in Alzheimer's dementia, not everyone will have Alzheimer's in their lifetime. So just to make it more confusing. Now, how do you know it's not dementia with Lewy bodies? I'm sure a lot of you have heard of Robin Williams, who was thought to have Parkinson's disease. And then after he passed away and they did a brain autopsy, they said, well, actually it was dementia with Lewy bodies. Well, what's the difference? How do you know? It's kind of on a spectrum. And in some ways, the way neurologists define this is a bit arbitrary, but someone with Parkinson's disease do not usually have major cognitive changes early in the disease, whereas someone with dementia with Lewy bodies has much more cognitive issues within 1 year of the motor symptoms. So if somebody has tremor, and then within a year of developing tremor, they start having hallucinations. Sometimes hallucinations can be subtle in the beginning. Sometimes it's just the feeling of someone is next to you and you turn and look and no one's there. Eventually can evolve to frank hallucinations where you see people or animals or children. Sometimes hallucinations can be disturbing, sometimes it's not. And then another more subtle symptom could be fluctuations in cognition. So what do I mean by that? Fluctuations in cognition is when someone has variability in how they are attending to their environment and to people. So sometimes they seem completely with it, and then other times they don't. And sometimes they're wide awake, and other times they're sleeping and hard to wake up. And so we see that more often with dementia with Lewy bodies, and it tends to happen earlier in the course of the disease. Now, I just made a list here of other symptoms that can be confused for dementia or depression. So we talked about how slowness of thought is seen in multiple types of Parkinsonism. So regular Parkinson's disease can have that, but I hear it a lot in patients with progressive supranuclear palsy and some of the other ones too. And when someone is slower to respond because they're thinking slowly, sometimes people can mistake that for memory loss or dementia, but in reality, you might just need to give the person a little more time to say what they want to say. Hypomimia, that flattening of the facial expression, can sometimes be mistaken for depression and vice versa, right? We talked about how depression can look like Parkinson's disease. Well, in someone who has Parkinson's disease, they may say, no, I'm not feeling depressed, but the loved ones feel like they are depressed because they lack facial expression. When in reality, that loss of facial expression is just part of the Parkinson's disease, and they may not be depressed. Apathy is really common too. So the loss of motivation, and apathy and depression can happen together, but again, they don't have to. And medication effects. So a lot of times when we treat someone with carbidopa levodopa, we think about how it's affecting the motor symptoms, tremor, walking, how fast can a person moves, how's their balance. But there's also effect on the non-motor symptoms. So anxiety, depression, thinking, cognition. And so sometimes when the medication wears off, some people feel like they are thinking worse or they're more anxious, etc. So, all right, so one more pause here. I want you to think about all the things I've said so far. And I hope that you've taken away something new from this talk. Maybe some of this was very familiar to you already, but hopefully you learned something new. And I would love to hear what you learned new from this talk. And of course, if you have any questions. These were some of the key points that I was hoping you would be able to take away. So understanding that Parkinsonism is a set of symptoms with many causes. So Parkinsonism, again, means slowness of movement, plus one of the following: tremor, rigidity, loss of balance. And although tremor is probably the most common reason why someone comes to me for evaluation for Parkinson's disease, not all tremors are related to Parkinson's disease or Parkinsonism. And there's a lot of overlap in symptoms in patients with Parkinson's disease, depression, and dementia. And so really, it takes a very detailed history and a thorough exam to really figure out what's going on. And that's what your neurologist tries to do in the office. And that is all I have. So I'm happy to take questions.
Okay, so just like our first session, any questions that you have for Dr. Paul can be put in the chat. And to be honest, we've got a little bit of a smaller group here, so if it's easier for you to come off mute and ask your question, that's fine too. But we'll start with the few that are in the chat. Can exercise reduce fatigue? The question was also raised about OAB, so overactive bladder, I think, that came up during our earlier session too.
So I love questions about exercise. I'm a big, I highly recommend that everyone should be exercising, even patients without Parkinson's disease, because it's really good for the brain. So can it reduce fatigue? Yes and no. So a lot of times when people start exercising, they feel more fatigued, right? Because you're pushing your body, you're trying to push yourself past your limits a little bit to build the strength and to challenge yourself. And so initially in the beginning, you might feel more fatigued, but over time, as you build up strength and you get used to the exercise, it actually can give you more energy. So if anyone's feeling fatigued initially from trying to do exercise, no one becomes a marathon runner overnight. So I encourage you to try to stick with it and take it incrementally, try, small steps, building up each day on it. And then overactive bladder, can exercise reduce overactive bladder? I don't think there's any data to suggest that. In general, we know exercise is helpful for the brain, but there's many reasons to have overactive bladder. So while Parkinson's disease can directly impact a person's ability to control their bladder, we also know that prostate disease can affect your ability to control bladder, right? And women who've, post-pregnancy can have a weakened pelvic floor, and that affects a person's ability to control their bladder too. So there's not really like, I can't say that across the board that exercise will help reduce overactive bladder, but it certainly wouldn't hurt.
Thank you. So there are some physical tests to determine whether someone has Parkinson's disease. Has there been any advancements in other tests to help identify PD? Is there a chance for misdiagnosis?
That's a great question. So there are physical exam maneuvers that we do in the clinic to determine if someone has Parkinson's disease. And really, we're looking for those signs of slowness of movement, the bradykinesia, the rigidity. So we'll feel your limbs and we'll, try to move your arm up and down and your legs. We'll ask you to tap your fingers. And we're looking at how fast you're tapping, how big can you make the taps. Those kind of things help us determine if someone has Parkinson's. Now, usually where there's a chance for misdiagnosis is if somebody might have one of those red flag symptoms that I mentioned before and it's not picked up. And so is, for example, if somebody does have equal symptoms on both sides of the body, I might want to take an MRI of the brain to make sure it's not related to stroke or vascular causes of Parkinsonism. I've had patients diagnosed with Parkinson's disease and then come to my clinic, and then I end up diagnosing them with something else, like dementia with Lewy bodies, or I had a patient who actually had progressive supranuclear palsy, but was initially diagnosed as Parkinson's disease. But to be fair, over time, symptoms progress and change. So a lot of times when we first see you in the clinic, that's one data point really, right? That's one snapshot of time. And we sort of need to see you over time to really determine, is this Parkinson's disease or something else? So a good example of that, progressive supranuclear palsy, part of the diagnostic criteria falls within the first 3 years of symptom onset. So if I'm only seeing you in year 1 and you don't have falls yet, that doesn't mean you won't go on to have falls within 3 years of symptom onset, right? And so that's why timing matters a lot. When you see your neurologist, it's really helpful to nail down when symptoms actually started. A lot of times my patients will tell me when symptoms became noticeable or worse, which is not the same thing as when it started, right? So somebody might have had a tremor for 7 years, but it only got worse in the past 2 years, right? So that's a big difference. And it helps us to know these timeline, because right now the diagnosis is still clinical and it's based on expert consensus on criteria. So each of these diseases have its own set of criteria, and we try to see how your symptoms fit together and which set of criteria does it fit the best. And that's how we determine if someone has Parkinson's disease. I mentioned the DAT scan. So there are these type of scans that you can do that the DAT scan helps us know that you have an underlying Parkinsonism, but it doesn't distinguish whether it's Parkinson's disease or if it's one of the atypicals. And same thing, an MRI brain can help tell us, okay, is there signs of vascular Parkinsonism? But a normal MRI of the brain doesn't tell you if you have Parkinson's disease. And so there aren't really any other better studies at this point. I know people are looking for biomarkers of Parkinson's disease. There are biomarkers of Alzheimer's disease. So sometimes if you're getting evaluated for Alzheimer's, they may ask you to do a lumbar puncture where they take some of the cerebral spinal fluid and they analyze that for the biomarkers of Alzheimer's. And that one is pretty sensitive, but we don't have something like that for Parkinson's disease just yet. We do have, I take that back actually, we do have skin biopsies. So skin biopsies look at the protein alpha-synuclein. That's the same protein that accumulates in the brain and causes Parkinson's disease. So if you see that in a skin biopsy, that helps narrow it down a little bit. But we see accumulation of alpha-synuclein in Parkinson's disease, in dementia with Lewy body, and also in multiple system atrophy. So it doesn't fully nail down the diagnosis, but it helps narrow it down. I hope that answers your question.
Yes, a very thorough answer, and it sounds like there's still more research to be done, but definitely helps with the, I think, understand that response to that question a little more. How does frontal temporal lobe disease fit in?
Okay, that's a good question. So frontal temporal lobe dementia is a type of dementia that causes personality changes, and sometimes that's the first sign that you see in frontal temporal lobe dementia. It's not necessarily part of Parkinson's disease. Now, can a person have both? Yes, in theory, a person can have both Parkinson's and frontal temporal lobe dementia. They're not necessarily mutually exclusive, but I would not say that they're the same disease or that one causes the other.
Thank you. So we are just about at time. The next session starts at about 1:50. So at this point, I put in the chat, if you have additional questions for Dr. Paul, you can email them to info@marylandparkinsonsupport.org, and we will forward them on to Dr. Paul to respond to. And also a quick reminder that after this session, we're returning back to the meyerberg.org/LWP site, page, and I will add that into the chat as well. And I also want to thank Dr. Paul for making time today to meet with us and to share your knowledge with us. And wish you a wonderful rest of the weekend.
Thank
And
you. It was my pleasure.
thank you. All right. Thank you so much. We'll see
Thank
you at
you.
the next session. Thanks.
This completes our current session. This meeting will end in 1 minute. Please proceed to meyerberg.org/LWP and click Join Session of the next session. Thank you.